Excellent, thank you. And I will second Corey in thanking you for sticking around so late. I'm going to touch on therapeutic drug monitoring, when, why, and how was the title I was given. And brief conflicts of interest. I'll tell you, I think my biggest conflict is that I am a huge believer and proponent of proactive therapeutic drug monitoring, so I'm going to try to focus the talk on that a bit today. So when, why to do TDM. We'll touch on reactive testing, which is I think what most of you are probably aware of, which is testing drug concentrations and antibodies when you feel a patient is having a flare. I'll show you a bit of data that better directs care, and there's data that it's more cost effective. Again, I'm going to focus on proactive TDM, show you that it improves outcomes. Also a bit of data that it's cost effective. Most of the talk will focus on proactive TDM during maintenance of therapy. That's when we have the most data. Although, to be honest with you, I think it's even more important in the induction period when those patients have a high clearance, high CRPs, low albumins. That's when they need more drug in order, A, to control the disease and make sure their drug concentrations don't become undetectable. When stopping an immunomodulator patients on combination therapy, we know there's data on using combination therapy, particularly with infliximab, but that data does not extend beyond 1 year. And I'd argue most patients would rather be on one drug than two, and there's certainly some potential adverse events with combination therapy. And then that leads into what I've sort of termed optimized biologic monotherapy, utilizing a biologic therapy, dosing to a therapeutic window, which we hope would make combination therapy unnecessary. So this is the Bridge RAND panel. This was sort of the question at the beginning, I guess they asked. So we sort of looked at this a few years ago. Bridge is a group of 13 of us IBD people who, when we started, were young. Now we're old. And we did this panel. It's called the RAND panel. It's an intense methodology, literature search, review of the literature, and then ranking different scenarios from 1 to 9, 1 being inappropriate, 9 appropriate. And basically what we found was it was appropriate to perform testing at the end of induction for patients with primary non-response, secondary loss of response during maintenance and responding, and restarting after a drug holiday, not before, but after the first dose, before the second infusion. That infusion is the highest likelihood of a severe infusion reaction. And then it was uncertain at the end of induction in responders, and that should look familiar. The AGA guidelines actually just came out, and I attached those here. These, I have to say, were, I would say, disappointing at best. They made a conditional recommendation in favor of reactive testing and no recommendation on proactive therapeutic drug concentration monitoring. Mostly they said due to a lack of data. I much prefer this Australian consensus, which came out, I think, about a month ago, which actually came out in favor of therapeutic drug concentration monitoring in each of the scenarios, including proactive TDM at the end of induction, as well as proactive therapeutic drug concentration monitoring in the maintenance phase if it's likely to impact management. So what's all the hubbub? Why are we talking about this? I would say, one, we know that patients, when started on an anti-TNF, about 2/3 are going to respond, and at a year, about half those are in remission, so not great results. There have been many of these cohort studies and post-hoc analysis with every agent and both UC and Crohn's disease that would tell you what you would think, that more drug on board correlates with better outcomes. And in fact, really, when you look at it, the higher the drug concentration actually correlates with even improved outcomes, from clinical response to remission to CRP normalization to endoscopic healing. What no one's ever shown to date is that high drug concentrations in IBD are associated with negative outcomes. So this also should look familiar. There's numerous things that affect the pharmacokinetics of monoclonal antibodies. And if you look at these, most of these actually negatively impact drug concentrations and increase clearance, including active disease. You can see high baseline TNF, not drug, but TNF, low albumin, high CRP, male gender, and people who are overweight. The one thing that does decrease clearance of drug is the use of a concomitant immunomodulator. And that, I think, is its benefit: decreasing clearance, increasing drug concentration, decreasing antibody formation. So again, reactive TDM, this is probably what most of you are doing. And this is the sort of algorithm. I won't go too into detail. What I would tell you is the most important thing here is confirmed disease activity, right? You need objective evidence of active inflammatory bowel disease before you go ahead and make any changes one way or the other. Then you can check drug concentrations. If you have a therapeutic drug concentration, that's theoretically where you're going to switch drug class to a different mechanism of action, or perhaps use surgery. This is a patient who is no longer TNF responsive. I would say this is a very rare patient, and in fact, one of the miscues that I see often is not optimizing the anti-TNF therapy based on reactive testing, and that really, unless your anti-TNF drug concentration, whether it be infliximab or adalimumab, is above, let's say, 10, you really should think about optimizing that before moving on, because not only are you moving on from that drug, you've now moved on from that class entirely. Subtherapeutic concentrations a little bit easier. If the antibodies are negative, you're just going to dose escalate. It makes more sense to decrease the interval than it does increase the dose. If their antibodies are positive, I wouldn't just move on. I would think about it a little bit more specifically. If they have high titer antibodies, that's where you're going to change to a different anti-TNF. This patient responded to the anti-TNF, lost response due to high antibodies. They should respond to another anti-TNF. If they have low-level antibody formations, you optimize that anti-TNF, decreasing the interval or increasing the dose, and I would consider addition of an immunomodulator. So this is where I want to really focus. This is proactive therapeutic drug concentration monitoring. I'm going to show you data. It improves clinical scores in CRP with just a one-time dose optimization, decreases the need for rescue therapy, prolongs duration of infliximab with less discontinuation, and we have recent data that it decreases IBD hospitalizations, surgeries, serious infusion reactions, antibodies to infliximab, and treatment failure when compared to reactive TDM. So this is not a new concept, right? We've been doing this forever. I did it in residency with gentamicin, vancomycin. I did it as a fellow at Mount Sinai using cyclosporin. Anybody who does liver transplants does this with tacrolimus. The concept's simple. You have a therapeutic window. In some drugs, particularly gent, dig, above a certain threshold, the drug becomes toxic. Below a certain threshold, the drug doesn't work, right? Patient doesn't take the drug, it doesn't work. Not enough drug on board, it's not going to work. With biologics, it's even more important because having no drug on board can result in immunogenicity, right? When we first started using these drugs, when infliximab was first approved, it was given on demand. Over 60% of those patients developed antibodies to infliximab. Right? If a patient is getting down to undetectable trough concentrations before their next dose, that's akin to dosing it on demand. So Taxit, this is the prospective study from Belgium that I think is often misquoted as a reason not to do therapeutic drug concentration monitoring. Took patients in one clinic rolling through on infliximab in a stable clinical response or clinical remission, and they basically dose optimized all patients, and that's important. Everybody got dose optimized to a drug window of 3 to 7. Then, and only then, were they randomized to standard of care, which is further dosing based on clinical symptoms or CRP, or continued sort of proactive therapeutic drug monitoring to their defined window of 3 micrograms per milliliter. The primary outcome then was only at 1 year. So I'll point out, with just one-time dose optimization. Those patients with Crohn's disease with a trough concentration less than 3 who got more drug to bring them up into that therapeutic window, you gained 15% of your patients who were just responding, now put them into remission, and I could show you a similar slide that shows their CRPs improved as well. No difference with ulcerative colitis because 90% of the patients were in remission with a normal CRP. So here's the issue. Here's their primary endpoint. They did not meet their primary endpoint. At 1 year, there was no difference. Why? 1, all patients were initially optimized, so all patients now started from a therapeutic window, or what they termed a therapeutic window. 2, then they only followed them for a year. And 3, their window is probably a bit subtherapeutic as well. They did, even with all those caveats, hit a number of secondary endpoints that favor proactive TDM. Less patients needed rescue therapy. Less patients had undetectable trough concentrations. And there was a similar cost between 2 groups. So one strategy was not more costly than another. So actually, even before the Taxit, we had started at our institution, basically started speaking to patients and talking to them about this concept of the therapeutic window and dosing patients on infliximab to a therapeutic window of here 5 to 10. I felt like it was the low number here that was more important necessarily than the high number. Similar to the Taxit trial aside, this is retrospective. As they rolled through, I would talk to them about this and then I would dose optimize them. If they were above 10, I would actually dose de-escalate, and Taxit did the same. We then took these patients, compared them retrospectively to a control group from our IBD center that received the standard of care, which was reactive TDM or empiric dose escalation. And what we found that the group that had proactive therapeutic drug concentration monitoring had much greater drug persistence, about 90%. And you can see the red line, the number of patients that were getting standard of care, how they dropped off significantly. Most recently, we in combination with the University of Pennsylvania, we looked retrospectively at now, the first study was about 120. This is now 260 patients with IBD. We looked at them in the maintenance phase on infliximab. They had responded. Then we looked at what their first TDM was for. Was it proactive TDM or was it done reactively? And then we looked at a number of different outcomes, which I'll show you here. So proactive TDM, and I would say this is not rocket science. I think this is common sense. Those patients that had proactive TDM had much less treatment failure than the group that had reactive TDM. And in this case, you want to be on the bottom because it's treatment failure, so about 10% treatment failure. It held stable for Crohn's disease when you broke out Crohn's disease and ulcerative colitis, and the curves even separated more for ulcerative colitis. And I think importantly, some harder endpoints here you can see proactive TDM was associated within the top left, that was less surgery, top right hospitalization, bottom left antibody formation, and bottom right serious infusion reactions. And there's data from Europe as well that drug concentrations kept above 3 are associated with less antibody formation. When broken out into quartiles, as you would imagine, that lowest quartile group, the basically undetectable group, those were the ones that was associated with the negative outcomes. Again, the surgeries, antibody formations, and serious infusion reactions. So again, this will be for there. This is today what I still do in practice, and I dose patients with infliximab to a trough greater than 5. We don't know the exact window. Maria Brew has evidence that perhaps perianal disease require higher windows. I do this for infliximab. I do this for adalimumab, and that I won't show today. So again, that's where most of the data lies, is in the maintenance phase. Again, I think it's even more important in the induction phase, even though we have less data. Why? It's active. This is when they need more drug. This is when they're really clearing the drug. I will show you data that early drug concentrations correlate with both short-term and, more importantly, long-term outcomes. So again, this is outpatients. This is a small European study. what I'll point out is 58% of the patients were in endoscopic response at week 8. What's important here is that infliximab concentrations at week 6 were higher, not surprisingly, in those that responded than those that didn't respond. Importantly, 6 out of the 8 non-responders already developed antibodies to infliximab, right? This is early, and it occurred as early as day 18. And again, the sicker patients didn't do as well, the higher CRP. This is data from one of my fellows when he was in Belgium that showed week 14 drug concentrations. Higher drug concentrations are associated with earlier or better short-term mucosal healing. And data from Marla suggests that week 14 infliximab concentrations of more than 7 are predictive of week 52 week or long-term persistent remission. Right? Those patients that just respond may do okay, their drug concentrations may become undetectable, develop antibodies, lose response is sort of how I would put most of that together. So what about proactive TDM? What about optimized monotherapy? What about dose de-escalation or stopping an immunomodulator? What's the data for combination therapy? Most people are going to point to SONIC trial, right? There are issues with this as well. There's a slight, albeit probably, I would say, clinically insignificant risk of hepatosplenic T-cell lymphoma and probably a low risk of, but nonetheless, real risk of opportunistic infections. And it's hard to get patients to take combination therapy, right? It's hard to get patients to even think about an anti-TNF therapy unless you have Corey's thing in your office. Not many people buy in that quickly. And so I really talk about optimized monotherapy as an alternative to combination therapy. If your goal is to get patients into a therapeutic window, do it with one drug. Why need 2? So again, SONIC is what people point to for why we use combination therapy. And I didn't even show you the original slide because one, I didn't have time and I'm probably going to run over anyway, but you know, the patients that got combination therapy did better than those that got infliximab alone, did better than those that got azathioprine. The question is why? And I think the answer is here. When you look here, when you looked at quartiles, the lowest quartile was mostly those patients that were getting monotherapy. So the lowest quartile infliximab concentration was mostly monotherapy in red, and the quartile on the right, the one with the highest infliximab concentration, was mostly made up of patients getting combination therapy. When you break it out and you see here, it wasn't the combination therapy that really contributed to the outcomes. It was really the drug concentration. So those in quartile 1, whether they're getting mono or combo, both did equally poorly when compared to the higher quartiles. So the way I sort of look at this, and again, this is post-hoc analysis, but I would say it's all about the drug concentration. We sort of talked about this in our original paper in 2014 when I looked at 31 patients who either dose de-escalated and stopped an immunomodulator or on monotherapy, or on monotherapy the whole time, and were able to achieve trough concentrations of greater than 3. And I would say the majority achieved trough concentrations of greater than 5. No patient was off infliximab at the end of the study, and the median follow-up time was about 3.5 years. Again, all with the caveats of a retrospective trial. Particularly if someone's on monotherapy, I would encourage you to continue to optimize and follow drug concentrations. So this is the other situation that you may run into this, those patients that you do have on combination therapy that either want to stop or if they've been on it a year, and really that's where the SONIC trial ended. And so what if they want to stop? And again, I would say check a drug concentration before, make sure it's optimized, and follow the drug concentrations after if you're going to stop the immunomodulator. The other thing to be aware of is if you stop an immunomodulator, your drug concentration is likely to fall. So again, this is just the data that whether a patient stayed on an immunomodulator, stopped an immunomodulator. At 1 year, it didn't seem to make a difference. The outcomes were both actually sort of equally disappointing. What they did see is CRP rose in the group that was on monotherapy, and the drug concentrations fell. This study I like. This was a study at DDW a couple years ago that showed in patients on combination therapy, if you continued azathioprine on the left, drug concentrations didn't change. If you just had the azathioprine in the middle, drug concentrations of infliximab didn't change. But if you stopped the azathioprine on the right, drug concentrations went from a median of 4 down to about 2. And importantly, you saw that the number of patients that had undetectable levels went up to about 40%, and you saw the antibodies sort of rise. So I sort of, in my head, if I'm going to stop an immunomodulator, my assumption is your drug concentration is going to go down by about half. What is the optimal drug concentration? This is, and I put a question mark there, is we really don't know. We don't know both on a population, and we certainly don't know on an individual. This is sort of what I do. I think I took out the slides based on what it is. I think reactive, it's important to really push it. First drug is the best drug. You don't want to lose it, and you don't want to lose the whole class, so greater than 10 to 15. Clinical remission, and again, with adalimumab or infliximab, if you're 5 and you're in a deep remission, I sort of leave you alone. If you're in clinical remission but not deep remission, I'm pushing you to drug concentrations of greater than 10. And again, I think week 14 or week 4 after induction, the numbers should be a bit higher as well. Again, I'm typically aiming for about a week 14 of 10 for infliximab and even 10 for adalimumab. What do the guidelines recommend, just so I'm not biased? Again, this is reactive. This is the AGA. Again, I think they didn't do a great service here. They said infliximab greater than 5 and adalimumab greater than 7.5. So basically, they're saying if your infliximab concentration is 6 in a reactive setting, you should move on. I totally disagree, and I think a lot of patients are going to get moved off drug that really just need to be optimized. The Australians, again, quoted relatively similar numbers, 3 to 8 for infliximab and 5 to 12 for adalimumab. But again, here they made it clear this was in sort of stable disease with luminal disease, and the bottom is important. They say some patients may need higher numbers. So what are the issues with it? Again, I touched on it. Optimal trough concentration window is unclear. The timing of the testing, again, most of this is with trough and in maintenance. I think in induction is even more important. Most importantly, we need a test that's accurate, accessible, and inexpensive. I think a lot of the drawbacks and a lot of the issues people have with TDM is that one of our tests costs a lot of out-of-pocket to our patient. Certainly, we'd like to see some prospective data on this. In practice, know your test. Is it drug tolerant? Can it detect antibodies in the presence of drug? Know the out-of-pocket cost to the patient. Know what to do with those antibody results, right? The antibodies are in different numbers. Know what to do with the results. I would suggest you can go to the Bridge website or the Australian paper. If nothing else, test reactively. But I still think proactive testing is the best, both after induction and during maintenance. And I'll just stop there because I've already gone over by 3.5 minutes.